So yeah, we'll just start. We'll start at about 104, so that'll give us about 30 more seconds here, Jen. And then we'll go ahead and get started. Welcome, everyone. Welcome. Thank you for being here with us. And Megan, I think I saw you join. Just want to confirm you're with us too. Great. I see you. Okay. Well, my clock, as of now, says 104. So I think we can go ahead and get started. Megan, I will pass it over to you to introduce yourself and get us going, and then I'll introduce myself. I just want to set a quick disclaimer before we get started. You all are welcome to use the chat during this presentation. Just know that I, at least, and Megan likely too, cannot be monitoring the chat while we're talking. So feel free to drop questions in there, and then we will circle back to those questions when we have an opportunity. And any other conversation or discussion is welcome as well. Just know that we likely won't be able to monitor that until the end of the presentation. All right, Megan, go ahead.
Hello, everyone. Megan Crane. I use she, her pronouns. I am the Zero Suicide and Health Systems Coordinator at Oregon Health Authority. And again, I'll be jumping in here the second half of the presentation. And if folks just want to confirm if they can hear me okay.
Yeah, you sound great, Megan, on my end. And my name is Taylor Chambers. Good afternoon. I serve as the Public Health Suicide Prevention Coordinator alongside Megan in the Public Health Division here at Oregon Health Authority as part of our cross-divisional suicide prevention team that oversees both Behavioral Health Division and Public Health Division, or sits across both those divisions. I have been having some audio bandwidth issues today. So if anybody notices like my audio doesn't seem to be catching up to where we are in the presentation, just let me know and I can turn my video off for better bandwidth too. My connections to this cause are varied and nuanced. I did lose my brother to suicide about 12 years ago, and I've lost my uncle to suicide, and myself have struggled since a young age with some chronic suicidal ideation. I mentioned that to say, alongside my personal connections, my background is also grounded in data, steeped in work with loss and attempt survivors, and based in epidemiology. And I say that to share that this work for me is personal as it is professional, as I know it is for many of you. Today, Megan and I have been asked to present on the most recent suicide data available through the Oregon Health Authority's Public Health Division Injury and Violence Prevention Program. That's a mouthful, I know it is, and so I don't anticipate you all to remember all of that. We have a no wrong door approach when it comes to reaching out to us here at OHA, and so if you know Deb Darmata, Jill Baker, or Shan Hotstetler just as well, you can reach out to any of them and we can get you connected to more data and sources as you need. So today we're presenting on finalized 2022 death data and emergency department and urgent care center visits through 2023. To note, we do not have enough time to highlight other data sources such as the Student Health Survey, qualitative and focus group data, Big River programming data, and much of the amazing work being done around the state by each of you in terms of training programs, awareness activities, and suicide prevention work. Before we dive into the data itself, I do just want to pause for 1 second so everyone can take a deep breath with me. And if you just want to take a deep breath in and out, because some of what we may be discussing today may be challenging to hear, and I want to acknowledge that. I invite you to hear the story the data tells, while I also encourage you to take care of your own needs. Permission granted to turn cameras off, step away, and do what you need to do to take care of you. As Jen mentioned in her email before this call today, slides will be made available following this meeting, and they are annotated as well, so you will have some of the data points in there. And as I mentioned, we will be answering questions at the end, but do feel free to put those questions in the chat at any point throughout the presentation, and whoever's not presenting will try to keep an eye on the chat too, but we will get to those at the end for sure. Next slide, Jen. So we're here for this ad hoc meeting because 2022 death data was recently finalized and the 2023 YSIP annual report was just released. Today we will be focusing on what the data is telling us, We don't have time today to dive into the limitations of the data and data systems, but we have covered that in presentations in the last year, which are linked to this PowerPoint, as well as in the YSIP annual report, which just went out as well. It is important to note that data systems, like our institutions, have been developed within systems of oppression and racism, and we recommend reviewing the presentations linked here as well as the annual report to learn more about the data systems and existing limitations. Data are imperfect. They have limitations, and while it's not perfect, it's what's available. So today we're focusing on what's available. The 2024 National Strategy for Suicide Prevention was just released as well. Two strategic directions we'll focus on in today's presentation are Strategic Direction 3 and Strategic Direction 4, surveillance quality improvement and research, and health equity in suicide prevention, respectively, which specifically looks at implementing comprehensive suicide prevention strategies for populations disproportionately affected by suicide, both in terms of highest suicide rates and communities with highest increasing rates of suicide. With a focus on historically marginalized communities, persons with suicide-centered lived experience, and youth, among others. And throughout this presentation, while reviewing data and data trends, you may hear Megan or myself use the term small numbers when referring to data. Small numbers are associated with estimates of lower statistical credibility and an elevated risk of a privacy breach. Estimates with few cases tend to be unstable and prone to misinterpretation. So, for example, it can be hard to answer questions around if certain Oregon youth suicide rates by race and ethnicity are increasing due to the low number of deaths per year. This is where we need to rely on larger state and national trends, and regardless of those counts, ensure these populations are considered in the suicide prevention, intervention, and postvention activities. I want to reiterate that any loss to suicide is too many. Any individual that dies by suicide deserves the dignity to be included to show value to their life and be considered in informing prevention efforts. We just need to balance that with privacy and that estimated risk of lower statistical credibility and elevated risk there. Next slide, Jen. So with those important caveats in place and some background setting done, let's dive into the data systems and the data themselves. Today, we're discussing what is a snapshot of some data sets, including 2022 finalized death data, 2023 emergency department and urgent care center data, and some administrative discharge data from sources that we maintain in the Injury and Violence Prevention Program. This slide may feel a little bit intimidating, at least it does to me. So to help with clarity of when to use which, the Injury and Violence Prevention Program has also developed a data glossary linked here to help you navigate the data sources. We are also in the process of developing a data dashboard glossary to help identify data sources, timeliness of data, and level of detail provided by each source. It can be a lot to try to manage all of these sources, so hopefully that dashboard that's coming will make that a little easier for folks, ourselves included. Next slide, Jen. So we're going to start today by looking at essence data. This is a summary of suicide-related visits to emergency departments and urgent care centers for all Oregonians under 18 through the Oregon Electronic Surveillance System for the Early Notification of Community-Based Epidemics, or essence data. It provides real-time data from all non-federal hospital emergency departments and select urgent care centers across Oregon. Included is emergency department and urgent care center visits for self-harm, suicide ideation, and suicide attempts. Here, pictured in this graph, we see suicide surveillance data from 2019 to 2023 for youth under 18. The green bold line is the 2023 data. We see that in 2023, the spring peak started slightly earlier in April as compared to May of past years, but the data is similar to the 3 previous years overall, noting that there were fewer total suicide-related visits in 2023 as compared to 2022. As a note, this used to be a static quarterly report that was available via email that anyone could sign up for. This has been transformed into an easily accessible data dashboard, which is linked in the resources as well. There you can explore data from 2019 to 2024 by age categories of 17 and under, 18 to 24, 25 to 54, and 55 or older. Next slide, Jen. So here we see suicide surveillance data from 2019 to 2023 for youth aged 18 to 24. Again, that green bold line is the 2023 data. And this data is similar to the previous 3 years, noting that there were, again, fewer total suicide-related visits in 2023 as compared to 2022. And next slide, Jen. So taking a step into death data, let's set the stage by looking at adults and youth. Across ages, Oregon historically has had a higher age-adjusted suicide rate as compared to the US nationally. However, we were one of 7 states that had a statistically significant decreased suicide rate in 2020 compared to 2019. In 2021, we saw the rate increase in Oregon as well as nationally. Again, in 2022, the rate increased nationally, while the age-adjusted rate decreased slightly in Oregon. This was a rate of 19.3 per 100,000 in 2022 for Oregon, compared to a US rate of 14.2 per 100,000. Again, that's age adjusted. Next slide, Jen. Despite a decreasing trend since a peak in 2018, the 2022 data marks the first year-to-year increase in youth suicide in 4 years. Oregon's rate of youth suicide in 2022 was 14.2 per 100,000. In 2018, Oregon's rate was 16.9 per 100,000. And in 2022, 109 Oregon youths died by suicide compared to 95 in 2021. I just want to let that sink in for a second, and also just to reflect that data can be really hard for us. So again, if you need to take a minute, whatever that is, please do. This annual increase, though, does not indicate an increasing trend from the peak in 2018 when 129 youth died by suicide. As a note, the state ranking varies based on not only Oregon's rate, but is based on the rates of other states across the United States. So it can be hard to compare across years for this too. And as another note here, Oregon does track suicides for age group 9 and under. However, some states do not track this or define these deaths as suicides. Therefore, to be comparable at the national level and for state ranking purposes, we separate out deaths for age 9 and under here. Next slide, Jen. So here's a graphical representation of the youth suicide trend in Oregon versus the US for those aged 10 to 17 years old. As an important note with the rates calculated here, we are talking about small numbers overall that can result in unstable rates prone to misinterpretation. So it's important to look at the trend over time and other data. As you can see for 10 to 17-year-olds, we hovered around the national rate until 2011 and then saw an increase. In 2019, the rate dropped below the national rate for the first time since 2010. The rate has continued to hover around the national rate since then, although in 2022, the rate went above the national average again, but was slightly lower than the rate in 2020. Go ahead to the next slide, Jen. And this is a graphical representation of the youth suicide trend in Oregon versus the US for those aged 18 to 24 years old. The youth suicide rate in Oregon in 2022 was 23.2 per 100,000 compared to 15.8 per 100,000 for the United States. While we did see a decrease in 2020, the rate began to increase in 2021, which continued in 2022. This is different than national data, which showed a decrease from 2021 to 2022. However, for Oregon, the 2022 rate is still lower than that peak in 2019 we saw. Next slide, Jen. Here's a chart of age-specific rates of suicide by sex in Oregon from 2018 to 2022. Suicide across the lifespan for all sexes is seen here in blue. For men, seen here in orange, suicide rates generally increase with age, while women, seen in green, see an increase through the middle years and then see decreased rates later in life. Just to highlight some context around this data, those aged 17 and under account for about 2.8% of all suicide deaths. Those 18 to 24 account for about 10% of all suicide deaths, while those aged 25 to 54 make up the majority of suicide deaths of 48%, and adults aged 55 and older account for about 39% of all suicide deaths. I'm going to turn it over to Megan for the rest of the presentation. So Jen, I'll have you go to the next slide and I'll turn it over to Megan.
So this slide characterizes youth suicide in Oregon in 2022. Again, this is a chart, a table straight from the YSIP. I do want to note that the race and ethnicity section on this slide has changed slightly from past years. We're providing more specific race categories, including separating out Asian and Pacific Islander. Also looking at non-Hispanic versus Hispanic. So this table is not comparable to previous tables, although we have added an additional table specifically for race and ethnicity that I'll reference later that can be looked at in the report. When we look at suicide, characteristics of youth suicide, age 24 and younger, we see that those aged 18 to 24 made up 78% of the total youth suicide deaths. There are significantly more males dying by suicide than females, which is also the case across the lifespan. Here you can see that males account for 82% of all suicide deaths. Again, race and ethnicity, we see white non-Hispanic youth having the highest rate. We'll provide some more context in that in a slide in a little bit. We also see firearm as being 52% of total deaths. Next slide. So as we get into talking a little bit more about race and ethnicity, just want to provide a little bit of context. We recognize and acknowledge that the data systems we have do not capture the complexity, culture, richness, and diversity of Oregonians. Data on race and ethnicity are used to identify health disparities and measure progress towards achieving equity. Historically, the focus has been on having people categorize themselves according to prescribed groups instead of how people self-identify based on their own lived experience. For instance, the federal government defines race and ethnicity as two distinctly separate entities, although many may view them as interchangeable and may not distinguish between the two. Family and friends of someone who has died by suicide are expected to choose only one category that best represents who the person is, and when that may not resonate with them or accurately reflect multi-ethnic or multiracial identities. In population-based surveys, certain racial or ethnic groups are often aggregated or grouped together to allow for more robust numbers for analysis. However, broad racial and ethnic groupings often mask important differences between more granular ethnic groups and do not acknowledge important differences in cultural, custom, healthcare beliefs, and practices. So again, we continue to try to do better at this. For example, in the last slide, including some broader or some more defined race categories, recognizing that we are trying to do better, and Oregon Health Authority has statutory requirements to increase race, ethnicity, language, accessibility, sexual orientation, gender identity, and other data categories. Next slide. So this is a new table that we've put in the YSIP annual report that, again, this is the table now where you can compare race and ethnicity across years as opposed to the characteristic table given the differences. This slide looks at suicide deaths from 2018 to 2022 by race and ethnicity. As you can see, the greatest number of deaths happen in non-Hispanic white youth, followed by Hispanic people of any race. What may be harder to see looking at this chart is that non-Hispanic white youth have trended down in deaths between 2018 and 2022. Next slide. Yes. So you can, oh, sorry, go back. So you can see the circles there, which show white non-Hispanic deaths in 2018 versus white non-Hispanic deaths in 2022. So in 2018, white non-Hispanic youth represented 74.5% of all deaths. And in 2022, it's 64.5% of all deaths. So while we see non-Hispanic white suicide counts going down overall from 96 deaths in 2018 to 69 deaths in 2022, we don't see that for American Indian, Alaska Native, Asian, Black, or Pacific Islander communities, or for those with 2 or more races or any race Hispanic. When we add up the counts for youth of color, we saw 32 deaths in 2018 compared to 38 deaths in 2022. So in 2018, youth of color accounted for 1/4 of all youth suicide deaths. In 2022, youth of color accounted for 1/3 of all suicide deaths. So again, just recognizing that we need to do a lot more for all of our youth, but recognize where we are seeing these trends. Historical disenfranchisement through genocide and institutional racism have resulted in American Indian and Alaska Native peoples experiencing poorer health and socioeconomic outcomes. Those social determinants of health intersect to create a situation that is detrimental to the physical and mental health of Indian communities. Cultural disconnection, alienation, and pressure to assimilate all contribute to higher rates of suicide among American Indians and Alaska Natives. However, cultural as prevention is a protective factor we need to lean into and work with the 9 federally recognized tribes of Oregon to work on. So again, while we see we don't create rates for these numbers, we look at percentage of total given the small numbers. As Taylor said, one suicide is too many. So we do look at the numbers, but we do see trends here that are important to call out. Next slide. So this slide is looking at suicide rates among youth by age group, 10 to 17 and 18 to 24, and by sex. I do want to make a note about what is called sex in the Oregon Violent Death Reporting System. Refers to individuals' gender identity at the time of death, and it includes transgender identities, people whose gender identity does not correspond to that assigned to them at birth. Gender identity is how a person self-identifies as a particular gender, regardless of biological sex characteristics. There is a separate variable for noting if an individual identified as transgender, and a person can be identified as male or female and also transgender. This data point was added to the data system in 2013. Transgender suicide deaths are not separated out in this visualization, although we will show one in the next slide, due to small counts. This is a limitation of the data set and does not allow for identification of people who identify as non-binary or other identity in any way. This is likely an undercount in our system due to data collection issues, as well as relying on family and friends to provide an individual's gender identity. So when we look at this table, what we see is a comparison age 10 to 17 in blue and those 18 to 24 in orange for sex, binary sex, from 2018 to 2022. We can see we see higher rates of suicide for males versus females, and higher rates for 18 to 24-year-olds versus 10 to 17-year-olds. Next slide. So this is where we can get a little bit of information around gender identity and sexual orientation. Between 2017 and 2021, 21 suicides were identified among transgender youth. And for that same period, 9 youth were identified as gay, lesbian, or bisexual. Again, this data is collected from medical examiner reports, police reports, and other information that may have been collected during the death investigation. While we're not able to evaluate transgender suicide rates due to small numbers, national evidence tells us that transgender women, men, girls, boys, and non-binary people are more likely than cisgender people to attempt and to die by suicide. This is not due to how they identify, rather due to issues such as transphobia, acceptance from their families, trauma, of experiencing rejection, and not having access to healthcare that supports their ability to live their authentic lives through gender-affirming healthcare. So we really do rely on some national trends here. According to the 2024 annual National Trevor Project survey, 39% of LGBTQ plus young people seriously considered attempting suicide in the past year, including 46% of transgender and non-binary young people. LGBTQ plus youth of color represented higher rates than white peers. And importantly, LGBTQ plus young people who reported living in very accepting communities attempted suicide at less than half the rate of those who reported living in very unaccepting communities. Again, showing some how acceptance and that work is suicide prevention. I will mention the Oregon Student Health Survey from 2022 shows that students who identify as other than straight or cis reported higher levels of depression, self-harm behavior, and actually attempting suicide than their peers. So we do have some data, Oregon data, that shows that similar trends to what we see nationally. Next slide. So now we are going to look a little bit into the emergency department and visitation data. This is from our Oregon Injury Prevention Dashboard, which again is a publicly available data. We're looking at ED and hospitalization data from the Hospital Administration of Oregon, an administrative discharge data set. So hospitals, Oregon hospitals send this data to OHA, and then it's analyzed. Here we see emergency department visits as a 4-year average rate by age category and sex. Females are represented in orange, while males are represented in blue. Contrary to death data, we see far more cases of suicide-related visits in females as compared to males aged 10 to 24. Note that the emergency department rate for 9-year-olds and younger is higher for males as compared to females, but these are small numbers with an average of 7 females and 10 males over 4 years. Again, with this data set, we are only able at this point to look at male and female. In hospital emergency department data, the available choices include only male, female, other, unknown, and refuse to answer. This too may result in undercount of non-binary and gender diverse individuals due to deficiencies in data collection. Additionally, the underlying counts of other, unknown, and refuse to answer do not meet data confidentiality thresholds and have been withheld to protect individuals' privacy. And just to define, when we're talking about suicide here, it includes all injuries due to intentional self-harm, thoughts of suicide, or suicide attempts in this data set. Next slide. So looking at the same data, this is broken down by binary sex as well as race. So if we look at all youth ages 24 and younger, we see the rate for Black or African American girls and women is the highest. Here are the numbers above the chart represent the total number for each reported race. So for example, 10,245 white girls or women under the age of 24 or less were sent to the emergency department from 2020 to 2022. About 16% of the emergency department visits, race was unknown, not reported or other, and 21 individual sex was other or unknown for this chart. And where this matches again what we saw the National Strategy for Suicide Prevention show in terms of seeing some increasing attempt rates among by race and gender. Next slide. So this is the same chart as before, but looking at ethnicity, we see that non-Hispanic females have the highest emergency department visit rate. And it's important for us to consider with the data presented that there are maybe reasons why folks may or may not present to the emergency department, which is another limitation to keep in mind when we consider this data. Next slide. So going back to death data, when we look at the percent mechanism of suicide by, again, binary sex for ages 10 to 17 for 2017 through 2021, we see that for males in this group are most likely to die by firearm compared to females who are more likely to die by hanging or suffocation. The other means represented here are drowning and sharp instrument. And compared to emergency department visits, this is different, where we see drug poisoning as the leading cause of method or mechanism. Next slide. This is the same pie graph as before, just looking at 18 to 24-year-olds by binary sex. We see a greater proportion of firearm deaths in males. Notably, 18 to 24-year-old females experience greater poisoning and firearm deaths compared to 10 to 17-year-olds, while hanging and suffocation remains the greatest cost. Next slide. So again, this is really presenting on 2022 finalized data, but we do have insight into 2023. Preliminary data in Oregon indicates that there will not be an increase in the youth suicide rate in 2023 as compared to 2022. Looks like it will be fairly similar. Oregon counties, while we have presented on state level data here, we know that we continue to see variations in suicide rates by county, with some counties seeing increases in suicide and some staying stable or decreasing. So recognizing that this data may not have felt relevant to your local community, and that we need to consider suicide prevention efforts at the local community while understanding state level data. We remain focused on working to prevent and reduce risk factors and increase protective factors for youth and their families and caregivers. While we still see our rate of suicide below our highest rate of 2018 for youth suicide, we need to ensure Oregon's progress in recent years is not lost. The risk of youth suicide continues to be a concern in Oregon. The data presented in this presentation is only part of the story of suicide in Oregon. Data related to evaluation and impact of programs and training and qualitative and lived experience narratives from communities play an integral role in our understanding of suicide and prevention strategies. Next slide.
So here are some additional resources for you. Most of the data discussed by Megan and I today, including limitations, can be found in the YSIP annual report that was just released, as mentioned, as well as the state's first adult suicide intervention and prevention plan, or the ASIP, and the forthcoming annual ASIP report as well. Linked here are the dashboards we discussed, some dashboards we didn't have time to dive into, and information around programming too. Next slide, Jen. I want to mention that this data is heavy and only a part of the story. The hopeful moments can easily be missed, and I want to acknowledge that each of you have a role in creating those moments for so many. I also want to reiterate the importance of taking care of yourself in this work. This work can be hard. It requires persistence and looking at data that can be challenging to live in and day out. Before we end, I ask you to share in the chat, what is that hope that keeps you able to do this work? What connections do you have to support you and fill you up? So it might be something from the Sources of Strength wheel pictured here in English and Spanish. It might be something from your colleagues. My colleagues, some of them are pictured here. It might be a bird that you see outside and brings you joy. So I'd love for people to drop in the chat what fills up their cup. Megan, thank you so much for helping me present today and co-presenting with me. We have lots of time for questions as well. If anybody wants to either raise their hand, come off mute, or drop them in the chat, we would welcome those at this time. And you can end the slideshow, Jen, too. Thank you so much.
I would just note that this was a presentation on youth data. We are working on an update on adult data as a part of our adult suicide intervention and prevention plan. So that will be coming. And we anticipate that OHA is going to be releasing a news release related to the youth data. Probably, we anticipate by the end of next week, although we don't have the exact date yet.
Great, thanks for that, Megan. I do recommend for those with us here still checking out the chat for some hope and inspiration. It's really bringing a smile to my face just looking at what brings you all joy in this work and what fills your cup up.
Taylor and Megan, do you have, would it be okay if folks have any questions now?
Yeah, absolutely.
Beyond what was in the chat already?
And I think I got to the questions in the chat, but if I missed any of them, now would be a great time to let me know and we can answer that verbally now. I'll just add a plug then. My and Megan's contact information is in the PowerPoint as well that will be sent out. If you have questions around data for your county or how to access some of the data we talked about today, where to look for national trends, we are happy to provide that to you. And as I've already mentioned, there's the no wrong door approach with the suicide prevention team. So if you email Shanda and say, hey, I need this data, well, she's on vacation this week, but when she's back, she will respond and let us know. Yeah, Mary.
Hi, everyone. I'm wondering with this data, with OHA and our Big River trainings, do you take that data then and tailor trainings to maybe more specific needs for our area versus nationally? I know there aren't that many differences, but there are some nuanced differences. I'm wondering if you're looking at maybe different focuses or different trainings that are available and maybe hit our students of need maybe a little bit more than just the generic trainings that we get.
Yeah,
Go ahead, Taylor.
I'll start to speak to this, then Megan, jump in whenever. Yeah, I think that's a great question. I think we have showed this time and time again that here in Oregon, we're willing to do things a little bit differently to address the population that we have here. And I think of examples like Oregon Calm, the Counseling on Access to Lethal Means training, where we assessed kind of what is happening in Oregon in terms of suicides and updating that presentation and training to really reflect the community we have here. So it's just one example there. And I think we are also, hopefully more to come on this, but looking into how we can culturally infuse suicide prevention trainings. And so we can identify where suicide prevention trainings that are evidence-based may really succeed and thrive and where they may need to be bolstered and where and when they may not be applicable for our audiences, applicable or not applicable. Megan, what else did you want to add to that?
Yeah, I think in terms of Oregon counseling on access to lethal means and addressing firearm safety with patients at risk of suicide, those courses that Taylor referenced, we're adding in pieces related to rural firearm owners or firearm owners in general, recognizing that there's a large firearm culture in our state and that we have high suicide firearm deaths. We also have been trying to, and then I think that's what I'll add. I mean, Taylor, I think we've tried to think about recognizing where we're seeing those decreases for white youth, some training that like for Latin communities, Youth Save for Black youth is being developed. So we're trying to identify where we have gaps, recognizing that a lot of the national suicide prevention trainings that we have as a field have not done a great job in designing courses or evaluating courses for non-CIS and historically underserved communities. So Mary, that's our response, and I appreciate hearing from you about what your thoughts there as well.
Well, I was just, thinking like when we train all the, Washington County, we train all the school counselors in assist. But assist is very, and it's a wonderful program, but it's not school specific. Not that it needs to be, but it does need to be too. If there was an option for those that are, say, more school based than a general population based, I think we could make it much more valuable to the people that we are having take it. And then just other things I'm thinking of, things that you can extrapolate from data. Like I do a little suicide risk assessment profile on all of our screenings, and notice that 36% of all of our screeners are with students who are in special ed. Right. So that kind of shows us as a district that we maybe need to do more work with, I don't know if Noel and ODE, if this comes into play or what, but where's our SPED departments and training our special ed case managers better? If that's, I hate to put more on people's plates, but I'm just wondering about the trainings. I'm so thankful for the free trainings that we have, but I'm wondering if we could tailor them to be more with the data that we have. Those are my thoughts.
Yeah, I think you're totally right, Mary. And I think you identify communities that, both in Oregon and nationally, we haven't necessarily done a good job of even understanding what the best practices would be for those communities, but we continue to try to understand what's going on nationally in other states. And thanks for that feedback. Annette, I see your hands up.
Yeah, thank you both for this presentation. Couple things that I'm struck by in it. One is that looking at you all have heard me say I don't feel like I'm much of a evaluation data brain person, so I'm always having to translate this stuff into how do I make this make sense to me. And that I was surprised by the number of Latino youth that died by suicide. Like when you looked at the actual numbers, it looked to me like other than white youth, Latino were the highest numbers, not the highest rate per population, but the highest actual numbers. And it just made me think about the work that's starting to be underway to try and do more work with Latino populations and with their families, et cetera. But it just kind of raised that into my awareness on another level, was to see like in terms of actual impact and deaths that are happening around the state. And then the other thing that I keep hearing as a theme in multiple settings is something that Mary brought up, which is the high number of young people who are disabled in special education that are showing up on screeners, that are showing up at hospitals, et cetera. And I've never seen any data around that. And I don't know if that's something we have a way to capture or not, but it seems to me like when we're looking towards the next 5-year YSIP, that's one of the areas we might really want to try and explore, spend time with.
Yeah, I think you bring up an excellent point. While again, the state has mandated, that OHA work with both internal systems and health systems on what we call Real D, or race, ethnicity, accessibility, language, and disability data. There's still work to do there. I do wonder if the student health survey has data there, although I would recognize that there are probably limitations in that student group who may take it. I'd have to look into that, but that's something Taylor and I could definitely go back to that team to understand if any, probably just at the state level as opposed to by county. At the state level, if any of that data is available by kind of mental health or any of the suicide related questions. But welcome feedback as well from others, but who might have additional data sources there. I think beyond that, Annette, we're really looking at national data, recognizing we have limits there, but there is some more national data for those communities.
Thanks everyone for the great questions, and Tim for your response in chat as well. I will encourage folks to look over there in the chat. And I did drop in the OHA page that talks a little bit more about the REAL-D and SOGI data and kind of the plans around House Bill 3159, the Data Justice Act there. So more learning there. Any other questions coming up for anyone that we might be able to either address or get back to you on answers?
I just one more question. As you look at the youth rates now, and I think at the beginning you shared sort of the adult overall rates, is the amount that it's gone up this year similar across the lifespan, or is the youth rate a higher going up rate of suicide? That's one of the things I'm trying to sort of figure out is the comparison between lifespan statistics and sort of the youth portion, which I know is a smaller portion of the full picture.
Yeah. Sorry, just trying to pull up the data. So so the lifespan data actually went down. I mean slightly, basically level. So in 2021, the rate was 19.5, and in 2022, it's 19.3. So I mean that's a decrease, fairly minimal decrease. So you know we kind of are talking about the youth suicide rate. You know, although we saw an increase this year, we're still continuing to see a downward trend since 2018. Whereas for lifespan, we're kind of seeing a stabilizing or plateau in the data. That's kind of the way we're talking about it, recognizing, you know, as we state in the report and talk about trying to look at, you know, multiple levels of years in the trend.
I really appreciate the thoughtful way you all frame this. And I think like that's one of the ways I'm listening to you is thinking about when I'm talking to other people, how to frame the data and talk with it about it. Because it's so easy when you're doing advocacy work to actually get into kind of catastrophizing and telling the horrible story. And it's not that there isn't a very sad story around suicide, and every suicide death is tragic, but balancing, I feel like you're doing a really nice job of balancing this hard information with kind of a realistic context and not being you know, overly dramatic about it, I guess. And so I just wanted to point that out.
I appreciate that. And let's be honest, it's a really hard balance, right? I mean, as Tim and I were talking through that presentation today, we're talking about lives. We're talking about families that are hurting. And we, you know, I think it's a both end. We can hold that there's a lot of work to do and a lot of suffering, and that, you know, the work that all of us have done in this room and beyond, you know, hopefully is making an impact. And you know, that we are doing work, everything we can. So yeah, so there's my just diatribe to the way you said it, Annette. But you know, I think we can hold both. We can hold both, that there is a lot of work to do, and and a lot of suffering in our state, and that, you know, I see a lot of hope in this room and through the work that people are doing every single day to try to make a difference. In terms of the data, I will just say, I know that Taylor shared the national strategy, but, and I'm not I mean, if you have time, go ahead and read the, I don't know, 200-page document. But being realistic, I do think there are the two data sections in the national strategy. Again, recognizing it's national data, but both kind of in the introduction and then in strategic direction 4. There's a small data section. Those are, you know, I think maybe 5-ish, maybe 10, but like less than 10 pages combined. It isn't a good overview. Again, recognizing it's national level, but I appreciate them providing kind of an overview, both related to suicide death data as well as suicide attempt data, recognizing that, you know, we've really incorporated that into our presentations, recognizing it's still only a piece of the picture, but it is an important picture for us to look at in addition to death data.
So when we send this, we'll send this out to everyone. When we send it out, we will copy in the many links that folks have gotten into the chat as well. So you all have quick access to those links if you want to go in and look more in depth in them.
And if you do, again, we are working on that, you know, adult data supplement, but the adult suicide intervention and prevention plan has, you know, has a lot of data in it that's slightly outdated, but again, you know, still very, very relevant, and, you know, worth taking a look at if you're interested in that population. You know, just recognizing today we didn't talk about service members, veterans, and their families, which is highlighted in that report. Kind of considerations around rural and urban areas and the higher suicide rates we see in rural areas. So again, you know, lots of data there, even though it hasn't incorporated in the 2022 data yet.
Right. Well, thank you so much, Taylor and Megan, for the presentation and for doing this. You know, a second time, we're preparing to do it a second time round since we weren't able to hear you at the quarterly. We really, really appreciate your flexibility.
It's not my favorite presentation to give every year for sure, but I appreciate it's important. So yeah, as Taylor shared, I think I'll let Taylor close it out, but hopefully you have at least a few minutes or longer to go and do something to decompress a little bit. Take a walk, pet your dog. Taylor, other closing thoughts?
Yeah, go find a cat, like just one on the street, become best friends with it, adopt it, take it home. Do that in the next 4 minutes. You have homework now.